All right, so I'm going to try to share with you some broad concepts and obviously share with you and discuss with you some tumors that are not common. I'm going to start with trophoblastic disease. Trophoblastic disease actually is more common than you would think. It's generally managed by OBGYN doctors. There are a couple of different variants, and this is not in NCCN guidelines, so I think this is important. The non-malignant gestational trophoblastic disease and the malignant versions, and I'm going to talk to you about that. The most common scenario is a woman thinks she's pregnant, has an ultrasound, and there's no baby in there. You see a snowstorm, kind of a grape-like scenario, and high dadidiform means grape-like. These are frequently size greater than dates. The high HCG levels cause benign cysts. They can have some complications, which I'm going to discuss, and ultimately they can recur and even become metastatic about 20% of the time. And the pathologist, will tell the OBGYN doctor that this is what she had, and these are diploid. In fact, there's no maternal DNA there. A partial mole is not nearly as dangerous, with malignant sequelae only 5 to 10%, and in fact, these are generally triploid. So there is generally some fetal components in a partial mole, and again, much less malignant. So what happens is that these women come in, they think they're pregnant, they're not. Sometimes they have some of these complications, particularly in the lungs. They can bleed. The OBGYN doctor can perforate the uterus because the uterus is so full of this grape-like tissue. The HCG can act as TSH. They can even have pregnancy-induced hypertension and then these benign cysts. So what happens is that the OBGYN doctor says, okay, ma'am, we did an evacuation and it's gone. We're going to watch the HCGs every 2 weeks. We're going to contraception so that if the HCG goes up again, it's not another pregnancy. And we'll see what happens, okay? And again, 20% of the time, these complete moles, which can happen maybe 1 in 100 to 200 pregnancies, they persist. So the HCG plateaus because it's a perfect tumor marker, or some metastases pops up, okay? And in that situation, it would be appropriate to refer these patients, which probably you're not that familiar with, for chemotherapy. And so you evaluate the patient, you do a comprehensive imaging of really the entire body, you do blood tests, and ultimately you come up with a score. So you take the patient's age, you say, well, she had a mole, she doesn't get a point for that. It's only been a few months since her pregnancy, doesn't get a point for that. Her HCG, though, is high. I can see a number of lung nodules. Again, lung, you don't get any points. There are a number of nodules greater than 8. Okay, so she gets 4 points from that, and after you add them up, she only gets 5 or 6 points. So 0 to 6 is low risk. Okay, so it's really not that complicated. Do X-rays, blood tests, do a score. Okay, and these scores are widely available, and they'll be available in your handout. And if it's a low-risk situation, you can give her single-agent chemotherapy, and I don't know which single agent to give. In this country, we do generally what's simplest. We give 35 to 50 milligrams per meter squared of intramuscular methotrexate, and we give it every week after week, until the HCG is negative, and then we give it 2 or 3 more times, almost a maintenance sort of scenario. And if that works, we continue to monitor her and keep her on contraception, and she's likely cured. However, if you did your scoring system, and this is where we really need your help, if you did your scoring system and it's greater than 6, then she has high-risk trophoblastic disease, and this again would be visceral metastases, a whole bunch of number of metastases, high HCGs, and then the standard is this regimen called EMICO. Okay, and EMICO, you give this for a week, etoposide platinum, and then you give the etoposide methotrexate Act-D and folinic acid rescue the next week, and you alternate week after week. And again, when the HCG then becomes negative, then you give 2 more weekly doublets of this combination. Okay, so it's a very common scenario. These cure rates are very, very high, and this is from the Charing Cross in London. I wanted to share this with you. So if you were to take 600 patients, okay, most of those patients will be low risk after the scoring system. They'll get either In our country, we give IM methotrexate. You can do methotrexate, folinic acid. Many of those patients, they're just going to be cured. If they're not, then you just cross over and you treat them with another single agent, actinomycin D, and those patients are going to be cured. Occasionally, though, there will be some high-risk patients or patients that fail methotrexate and actinomycin D and get to Emico, and again, almost all of those patients will be cured. So the cure rate is very, very high so long as you stay on the patient. Remember, the biggest risk factor for failure is incomplete therapy and drug resistance. Okay? And you can email us or call us. We're always happy to help you with these sorts of rare scenarios. So what else is rare? Well, germ cell tumors. Remember, when we talk about ovarian cancer, there's three types: epithelial tumors, stromal tumors, which are really granulosa cell tumors, and those are treated surgically, and then germ cell tumors. And germ cell tumors are very similar to your experience in testicular cancer. Fortunately, in GYN, most of these are stage 1s, okay? Occasionally, we'll find some patients that are widely metastatic with ascites. And it's the sort of germ cell types that you're familiar with. Most of ours are dysgerminoma, yolk sac tumors. Occasionally, we'll have an immature teratoma within a mature teratoma. And sometimes, in these teratomas, the monodermal layer, such as a thyroid, can cause a thyroid carcinoma in the ovary, or a squamous cell carcinoma in the ovary, or a melanoma in the teratoma, okay? And those tumors are treated just like solid tumors in other parts of the body. But when I say germ cell tumors, I really mean dysgerminoma, yolk sac tumor, or immature teratoma. And you can kind of figure this out preoperatively with tumor markers, alpha-fetoprotein, HCG, and LDH. We also sometimes use some of these others, CA125 in particular. And when you're treating these patients, you monitor them. So, for example, with yolk sac tumor, alpha-fetoprotein is almost a perfect marker like HCG is in trophoblastic disease. And how do you treat them? Well, just like you do in testes cancer, although we have not peeled away the drugs the way you have in testes cancer. So we give BEP, and we don't know the value of peeling some of these away and giving one or two of these drugs. We always give three drugs for 3 cycles, always. In fact, we'll give 4 cycles if there's residual tumor or if there's a stage 4 cancer. And the trick really is knowing when not to treat. So if there's a pure dysgerminoma and it's confined to the ovary, or an immature teratoma that's low grade, no additional therapy, okay? And so it's BEP, it's the way you know how to do it. It's the standard 5 days of platinum, 5 days of etoposide, and then weekly bleomycin, okay? And you can ask us, well, why do I have to give the bleomycin? Why can't I? In testes cancer, we peel these away. We've never done those studies. So these are reproductive age women generally, and this is the way we do it. So I'm going to transition to uterine mesenchymal tumors. Again, these are extremely common because most of these are leiomyomas or fibroid tumors or benign, but certainly there's a spectrum up to leiomyosarcomas, and you understand soft tissue sarcoma as well, and leiomyosarcomas are within that spectrum. There's endometrial stromal sarcomas, and then some of these mixed, but basically carcinosarcomas. So when I say uterine malignant sarcomas, I really mean leiomyosarcoma, endometrial sarcoma, and carcinosarcoma. So I'm going to talk to you very, very briefly about leiomyosarcoma because you, again, see these patients not uncommonly. We've tried to do drug discovery. The most active drug in uterine leiomyosarcoma is gemcitabine, okay? Doxorubicin is also active here, 16%, okay? So we extrapolate from the non-GYN sarcoma literature to gynecologic sarcomas, and again, gemcitabine is the most active. Here's a randomized phase 2, just 2 years old, where gemcitabine outperformed for survival compared to dacarbazine. Not all GYN, but a lot of these were GYN indeed. And the combination, gemcitabine with docetaxel, is better than single-agent gemcitabine. Again, a randomized phase 2 trial comparing gemcitabine alone, PFS on the left, and OS on the right. So the standard regimen for leiomyosarcoma is gemcitabine docetaxel, period, end. Okay? Now, what happens is that the OB/GYN doctor will send you a patient, say, medical oncologist, I did this hysterectomy. I understand that 30 to 50% of these patients that the cancer is going to come back. Should I give him chemotherapy, or should you give him chemotherapy? And you say, I don't know. And she says, I don't know. And you call me and I say, I don't know. Okay? But here's a 47-patient phase 2 trial that when they gave this gemcitabine docetaxel at this dose, remember the docetaxel is given on day 8, relatively low doses compared to other tumors, that 22% came back versus what we're used to, 30 to 50%. I don't know if that's better or not. It's a comparison versus historical control, but many of us, give adjuvant docetaxel gemcitabine after a hysterectomy where they thought they got it all. Woman just thought she had a fibroid. The OB/GYN doctor gets the pathology back. It's a high-grade leiomyosarcoma, sends it to you for adjuvant chemotherapy. We're going to do a randomized trial looking at adjuvant chemotherapy. It's not open. It's going to be tough. If you see a patient with recurrent disease, this study is open. Again, the standard is docetaxel and gemcitabine, and this trial just adds bevacizumab to it. The beauty of this trial is that you get the bevacizumab free, funded through the CTEP mechanism. This is for recurrent disease. And then you're familiar with the recent FDA approval of pazopanib. On that label is uterine leiomyosarcoma, okay? And if you look at here, this kind of rust color, leiomyosarcomas perform about in the middle of the soft tissue sarcomas that are on label for pazopanib. Here, actually, progression-free survival is a little worse. They're generally in the middle. I can't really read it here, but they're generally in the middle. But pazopanib would be an FDA-approved treatment after you fail docetaxel gemcitabine. The other types, again, are mixed Mullerian tumors, carcinosarcomas. These are polypoid lesions. These have biphasic, meaning that they have carcinoma and sarcomatous elements. When the sarcomatous elements is not generally present in the uterus, like a rhabdomyome, because there's no skeletal muscle, or osteo, it's called a heterologous. And the standard regimen for carcinosarcoma is ifosfamide and paclitaxel, okay? We did a randomized trial, ifosfamide, which is the single most active agent at that time, versus ifosfamide paclitaxel with Mesna, and there was a survival advantage. And we hate it. You hate ifosfamide paclitaxel, and so do I, okay? So we're trying to compare it to what you like, carboplatin and paclitaxel, right? So this study is ongoing. I think at my center we have almost 15 patients on this, comparing, again, the standard, ifosfamide paclitaxel, to carboplatin paclitaxel. This study will probably report in about 2 years. It's been open for 4. Now, endometrial cancer, I'm going to go quickly. Endometrial cancer, again, like all of our tumors, is a heterogeneous group. And you notice whenever I start to give a talk, I begin to break it out into groups. It's our attempt at personalized medicine. And the 2 types of endometrial carcinoma are what I call these type 1 tumors, which happen in obese patients, hyperplasia, and then endometrioid tumors. And then these that happen in older patients through mutations, and basically are high-grade serous tumors, okay, occasionally clear cell cancers. And when you see a patient with recurrent endometrial cancer, it's about 50-50, okay? So if a patient has metastatic disease at the time of diagnosis, okay, metastatic disease at the time of hysterectomy, the treatment is chemotherapy. It used to be radiation. This is a pivotal trial comparing radiation to chemotherapy. Now, it's whole abdominal radiation, but it was full dose pelvic. They tried to do even more because they thought the chemotherapy was going to win, and they were right, even when you radiate the entire abdomen. So chemotherapy beats radiation when endometrial cancer is diagnosed in the metastatic setting, in the lymph nodes, for example. So, or the OB/GYN doctor does a hysterectomy and there's a nodule on the peritoneal cavity. You give him chemotherapy. Now, this was the old chemotherapy. This was doxorubicin and cisplatin. I'll talk to you about kind of what the current regimen is. It begs the question, maybe we should do both, radiation and chemotherapy in the newly diagnosed metastatic setting. That's never been tested. That's being tested here. So we give cisplatin and volume-directed chemotherapy and then additional cycles of carboplatin paclitaxel. You may say, now listen, you just showed us a trial of doxorubicin cisplatin. That's the old chemotherapy. In GYN, carboplatin paclitaxel, you'll almost always win. So in fact, in recurrent disease, I'm going to skip those slides. In recurrent disease, we did 3 drugs, doxorubicin and cisplatin and paclitaxel, versus, again, carboplatin paclitaxel, because we hate the 3 drugs, we like the 2 drugs. We did a non-inferiority trial. So the chemotherapy really standard in endometrial carcinoma, no matter what the cell type is carboplatin paclitaxel. It used to be doxorubicin cisplatin. It used to be 3 drugs, doxorubicin cisplatin paclitaxel. I'm showing you here the 3-drug regimen versus the 2-drug regimen, non-inferiority, okay? So when you do a hysterectomy and it's metastatic, you give chemotherapy. And should you also give radiation? I don't know. We're looking at it, okay? And what's the right chemotherapy? Well, it used to be doxorubicin, but now, and a combination, but now it's carboplatin paclitaxel. Pretty simple. Now, the real question is what do you do when carboplatin fails? I don't know, okay? Clearly, doxorubicin is active, and that's probably your best chance. In fact, what a lot of people will do is they'll give liposomal doxorubicin. It doesn't work very well, okay? I mean, there just aren't good options after failing carboplatin paclitaxel and endometrial carcinoma. You may say, well, the PI3 kinase pathway is activated. I want to give her an mTOR inhibitor. Okay, fine. It's not going to work very well. You may say, I want to give her hormones, MEGACE, and aromatase inhibitor. Okay, fine. It's not going to work very well. So it's a chemotherapy world in endometrial cancer. So I have 3.5 minutes to talk about my favorite disease, cervical cancer. I chair the Gynecologic Oncology Group Cervical Cancer Committee. When I say favorite, I hate this cancer. It's completely preventable. It's completely preventable. We can test for the virus, the HPV virus on the cervix, and we can vaccinate to prevent infection. Screening and vaccination should eradicate this disease. This is the operation that we do. It's a radical hysterectomy. You can see this cauliflower lesion. We do it when the cancers are deeper than 3 millimeters. It's a bigger operation, a radical hysterectomy, compared to the standard hysterectomy. The standard hysterectomy is an endometrial cancer operation. A radical hysterectomy is a cervical cancer operation. And when there are 2 of the following, deep invasion, large tumors, or vascular invasion, we give radiation. And when there's 1 of the following, it's a positive margin or a node, we give chemotherapy and radiation. Okay? And you know how to give chemotherapy and radiation to cervical cancer. It's weekly cisplatin. I'm going to skip these slides and show you it is weekly cisplatin giving 40 milligrams per meter squared every week, 5 or 6 doses. Level 1 evidence, NCCN guidelines, New England Journal publication, while the whole pelvis is being radiated, okay? And it really substantially increases the cure rate. And you also do it if it's in the lymph nodes after radical hysterectomy. And if it's not in the lymph nodes after radical hysterectomy, as I already said, just radiator, okay? Now, systemic disease has been interesting. It's been one of my areas of research. Years ago, it became clear to me that HPV E6, through its binding and inactivation of P53, increased vascular endothelial growth factor and angiogenesis. And in fact, it became clear as I looked at the cervix while lesions progressed from early to more advanced dysplasia that I was looking, Rob, at angiogenesis out of control. The colposcopic findings on the cervix are blood vessels. These little mosaic, okay, that is a blood vessel breaking through the epithelium, okay? Demonstrates abnormal vasculature and angiogenesis dependent. I'm going to talk to you about that in a minute. We did a trial that I was privileged enough to report on looking at the platinum doublets that you use in lung cancer, okay? Because this is cervical cancer has a lot of same shared biology, and we showed that platinum and paclitaxel were the best, I'm not going to get into the details, okay? And the beauty of it is, again, since we hate cisplatin and 24-hour paclitaxel, the Japanese just this year at ASCO showed a non-inferiority to the inconvenient cis and 24-hour paclitaxel to what we want to do for all of our tumors, carboplatin paclitaxel. So they did this 24-hour inconvenient to the experimental arm and showed non-inferiority. So now for the first time I can go around and say, just like in endometrial cancer, the chemotherapy is carboplatin paclitaxel here in cervical cancer as well. Kind of boring, I get it. This is not boring, okay? So we did a study trying to add bevacizumab to chemotherapy, platinum taxane basically, and to try to get rid of the platinum because patients were getting platinum with the radiation. And then when they recurred, we were giving them platinum again. So we did topotecan paclitaxel, trying to get rid of the platinum, or paclitaxel platinum, and then asked the Bev question. And as it turns out, this adding or replacing the platinum with topotecan was not beneficial. But when you added bevacizumab, it was. Okay? It was beneficial in a way that is not the way it's beneficial in ovarian cancer. And in fact, because it has a survival advantage in cervical cancer, the NCI, very unusual, released a press release here just a month ago. Okay? And when you add bevacizumab basically to platinum taxane chemotherapy, you increase the survival from 13.3 to 17 months, highly statistically significant. They had more side effects, but these were not unusual side effects. Okay? And then, this is the only abstract that has been released by ASCO this year. So we sent the abstract to ASCO. ASCO abstracts are generally embargoed to May 15th. They said that we can't embargo this. So they made a formal policy exception and released this, what we call GOG 240, adding Bev to chemotherapy on the ASCO website, and showed just what I said, including not only an improvement in overall survival, but an increase in response rate. Okay? So I finished my medical school in 1988, and we have tripled the survival in recurrent cervical cancer by taking single-agent platinum, adding drugs, ifosfamide, ultimately paclitaxel, and now bevacizumab. So the treatment for recurrent cervical cancer, based on level 1 evidence overall survival, is platinum, taxane, and Bev. Brand new. I can't show you any of the curves. I can't show you any of the adverse events, really, because you got to wait for ASCO. But because the NCI released the press release, I think I have a duty to share that with you. And this is what I'm talking about. These are the 3 solid tumors that you like to add Bev to. First line, metastatic colorectal cancer, okay? There's a 5-month improvement, hazard ratio 0.66. This is non-squamous lung cancer, 2-month improvement, 0.8. This is either topotecan Taxol platinum or Taxol topotecan with Bev, almost a 4-month improvement, hazard ratio. So this is very consistent with what you're doing in other solid tumors. So I'm going to stop there.